Approach to a case of hemoptysis. Presented by Dr. Jalal, Mohsin, Uddin, M.B.B.S, D.T.C.D, F.C.P.S, Pulmonology. Assistant Professor of Respiratory Medicine. Hemoptysis. Hemoptysis is the expectoration of blood or blood-stained sputum that originates below the vocal cords from tracheobronchial tree or pulmonary parenchyma. A spectrum that varies from blood streaking of sputum to coughing up of large amounts of pure blood. On the basis of clinical urgency of management and volume loss, it can be classified as 1 massive and 2 non-massive. Arbitrarily, hemoptysis can be designated as follows. Mild hemoptysis is less than 20 ml of blood in 24 hours. Moderate hemoptysis is 20 to 200 ml in 24 hours. Severe hemoptysis is 200 to 600 ml in 24 hours. Approach to a case of hemoptysis. When approaching a patient with hemoptysis, a proper history has to be taken to narrow down the etiology of the patient's symptoms. The physician should first exclude the possibility of pseudo-hemoptysis and then narrow down the groups of causes for true hemoptysis. It is also paramount to quantify the amount of blood loss and evaluate for any complications due to blood loss. This includes evaluation of signs and symptoms of anemia and searching for signs of hemodynamic compromise. The patient's vital signs should be measured and documented. Criteria for admission to the emergency department. High risk of massive bleed. Gas exchange abnormalities. Respiratory rate greater than 30 breaths per minute. Oxygen saturation less than 88% room air. Hemodynamic instability. Example: tachycardic, tachypneic, hypertensive patient. Other respiratory comorbidities. Example: previous pneumonectomy, chronic obstructive pulmonary disease, and other comorbidities. Example: ischemic heart disease, need for anticoagulants, antiplatelet agents. Pseudo-hemoptysis. It is important to differentiate between pseudo-hemoptysis and hemoptysis. Etiologies of pseudo-hemoptysis include the upper gastrointestinal tract and upper respiratory tract. Differentiating features of pseudo-hemoptysis. Etiology. History. Physical findings. Laboratory test. Upper gastrointestinal tract. Coffee ground vomitus, black tarry stools, nausea, vomiting. Epigastric tenderness, signs of chronic liver disease, spider nevi, pulmonary erythema. Acidic blood pH, blood mixed with food, esophagogastroduodenoscopy, blood in nasogastric aspirate. Upper respiratory tract. Bleeding gums, epistaxis, no cough or sputum, sore throat. Gingivitis, telangiectasias, pharyngitis, ulceration. Nasopharyngoscopy. Common causes of hemoptysis can be broadly grouped into 5 main categories. Infective, neoplastic, vascular, autoimmune and drug-related. Detailed history taking and careful physical examination are necessary to provide a diagnosis and assess the patient's hemodynamic status. 1. Infective. A. Pneumonia. B. Bronchiectasis. C. Fungal infection. Example: aspergilloma, invasive aspergillosis. D. Lung abscess. E. Tuberculosis, non-tubercular mycobacteria. F. Acute bronchitis. G. Parasites. Example: hydatid disease. 2. Neoplastic. A. Primary lung cancer. B. Lung metastasis. C. Bronchial adenoma. 3. Vascular. A. Pulmonary embolism. B. Pulmonary arteriovenous malformation. C. Pulmonary hypertension. 4. Autoimmune. A. Systemic lupus erythematosus. B. Goodpasture syndrome. C. Wegener's granulomatosis. D. Diffuse alveolar hemorrhage. E. Granulomatosis with polyangiitis. 5. Drug-related. A. Anticoagulant. B. Antiplatelet agent. C. Iatrogenic cause. 6. Blood disorders. A. Leukemia. B. Hemophilia. 7. Traumatic. A. Lung contusion. B. Penetrating injury. 8. Iatrogenic. A. FNAC. B. Lung biopsy. C. Bronchoscopic biopsy. 9. Cardiovascular disease. A. Acute left ventricular failure. B. Mitral stenosis. C. Aortic aneurysm. 10. Others. A. Foreign body. B. Pulmonary endometriosis. 11. Unknown. You can remember battle camp. Causes of hemoptysis. Battle camp. Battle camp. Bronchitis. Bronchiectasis. Aspergilloma. Tumor. Tuberculosis. Lung abscess. Emboli. Pulmonary. Coagulopathy. Autoimmune disorder. SAF malformation. Avenue malformation. Alveolar hemorrhage. Mitral stenosis. Pneumonia. Etiologies of hemoptysis. History taking. 1. Infective causes. Pneumonia is a common cause of hemoptysis. In such patients, physicians must look for symptoms and signs of infection such as fever, chest pain and productive cough. In pneumococcal pneumonia, patient may present with rusty sputum. It is also important to obtain any relevant contact and/or travel history. Tuberculosis is a common cause of massive hemoptysis. It is hence prudent for a practitioner to look for risk factors of tuberculosis. This includes immunosuppression, which may be secondary to immunosuppressive medications or conditions such as human immunodeficiency virus infection or diabetes mellitus. Footnote: Rasmussen's aneurysm. Rasmussen's aneurysm is an inflammatory pseudo-aneurysmal dilatation of a branch of pulmonary artery adjacent to a tuberculous cavity. Life-threatening massive hemoptysis from the rupture of Rasmussen's aneurysm, black and white arrow, is a complication of cavitary tuberculosis, TB. 2. Neoplastic causes. Causes of hemoptysis in neoplasm include neovascularization in and relative to the neoplasm, exfoliation of the tumor surface, tumor necrosis, irritation of tumor from cough. Neoplastic lesions that can cause hemoptysis can be divided into primary pulmonary lesions and metastatic lesions. If a malignant cause is suspected, physicians should consider a thorough history and examination to look for other primary malignancies such as history of breast, kidney, gastrointestinal, ovarian and cervical cancers. It is important to also elicit constitutional symptoms such as loss of weight and appetite, and to consider the risk factors for primary lung carcinoma such as smoking and occupational exposure. 3. Vascular causes. Vascular causes of hemoptysis include pulmonary embolism. In patients with suspected pulmonary embolism, the physician should ask if they have a history of recent surgery or immobilization. The limbs should be assessed for any signs of deep vein thrombosis as well. Other signs and symptoms to look out for include dyspnea, chest pain, tachypnea and tachycardia. 4. Autoimmune causes. Vascularity crash, hematuria, joint pain or swelling may be suggestive of underlying autoimmune diseases such as Wegener's granulomatosis, granulomatosis with polyangiitis. Systemic lupus erythematosus, SLE, or Goodpasture syndrome. The characteristic butterfly rash or other skin lesions such as alopecia in SLE may also be found. If autoimmune disease is suspected, the patient should be referred to a specialist center for further evaluation. 5. Drug-related causes. Common drugs that may cause hemoptysis include anticoagulants, antiplatelet agents, NSAIDs, bevacizumab, Avastin, and sildenafil. It is important to elicit further history, that is medication history, in order to predict the consequence of stopping medications as part of management. Investigations. Chest radiography is typically recommended for all patients who present with hemoptysis. It is a quick, readily available and cheap modality that can assist in revealing any focal or diffuse parenchymal involvement. Other diagnostic modalities include bronchoscopy, computed tomography, CT angiography and digital subtraction angiography. When a patient with non-massive hemoptysis has no hemodynamic instability, a normal chest radiograph and low risk of massive bleeding in the acute setting, no additional testing is required. For accurate diagnosis, we can arrange other investigations according to the provisional diagnosis later on. In a patient with increased risk of malignancy, that is 30 pack per years of smoking, age greater than or equal 40 years, a referral for CT should be considered. History and physical examination. Rule out pseudo-hemoptysis. Chest radiography normal. Infiltrate mass or other parenchymal disease. Antibiotics CT thorax. Resolution no resolution specific diagnosis no specific diagnosis. If repeat chest radiography in 6 to 8 weeks. Chest CT, consultation with respiratory specialist. Further evaluation and treatment based on diagnosis. Bronchoscopy, consult iron with specialist. Massive hemoptysis. Massive hemoptysis. Massive hemoptysis is defined as loss of at least more than 600 ml of blood in 24 hours or 50 ml per episode. Although massive hemoptysis accounts for only 5% of hemoptysis cases, it is an alarming symptom with an associated mortality of more than 50%. May be usefully defined as any amount of blood that is hemodynamically significant or threatens ventilation. The initial management goal should not be diagnostic, but therapeutic. Causes of massive hemoptysis. Tuberculosis is the most common cause worldwide. The etiologies of massive hemoptysis are tuberculosis, bronchiectasis, lung abscess. Others, for example aspergilloma, fungus ball, etc. Source of massive hemoptysis. Bronchial arteries, 90%. Pulmonary arteries. In a case of massive hemoptysis with hemodynamic instability, the patient's airway, breathing and circulation should be managed first. Massive hemorrhage. Airway. Respiration. Circulation. Initial assessment. Initial assessment of vital signs, established a reliable IV channel. Arrange grouping and cross-matching. In some cases, active treatment may be inappropriate and palliative treatment with oxygen too and sedatives may be warranted to reduce restlessness. B. Airway protection and ventilation. Protection of the non-bleeding lung is vital to maintain adequate gas exchange. This may involve either sitting the patient up or lying on the bleeding side, to prevent blood from flowing into the unaffected lung and causing asphyxiation. Bleeding site can be assumed by seeing the old X-ray or CT scan of chest, but when bleeding is uncontrolled, intubation with a double lumen tube become mandatory. If intubation is not needed or not appropriate, give high-flow oxygen. See cardiovascular support. Fluid resuscitation ± transfusion. Inotropes may be required. De-establish hemoptysis. 1. Non-invasive measures. Nebulized adrenaline, 1 ml of 1 to 1000 made 5 ml with normal saline, may be applied. Oral or IV tranexamic acid / aminocaproic acid etc. IV terlipressin, 2 mg IV, then 1 to 2 mg every 4 to 6 hours if continued bleeding, analog of vasopressin, not used in eye hospital practice, commonly used bleeding esophageal varices. 2. Localization of bleeding site and achievement of hemostasis. CXR plus chest CT, depending on stability of patient, as patient may need to transfer to radiology department. Early bronchoscopy, diagnostic and therapeutic. Rigid bronchoscopy is preferable. May allow localization of the site of bleeding, balloon tamponade with a Fogarty catheter. Bronchial artery embolization, usually with coils or glue. Treatment of primary condition. Surgery, resection of bleeding lobe, if all other measures have failed. Role of bronchoscopy. In the acute phase it is difficult and often merely shows bleeding site as airway may be covered with existing blood. If radiology shows an obvious central cause, then rigid bronchoscopy under general anesthesia may allow intervention to stop bleeding. Bronchoscopic modalities. Endobronchial. Less than balloon tamponade. Bronchial irrigation with cold normal saline. Local application of hemostatic agents. Example aminocaproic. Vasoconstrictive agents. Example, adrenaline. Argon plasma coagulation, APC. Lasers. Thermal therapy, cautery etc. Argon plasma coagulation, APC. Protection of airway. Single lumen ETT. Selectively intubate the non-bleeding lung. Double lumen ETT. Specially designed for selective intubation of the right and left main bronchi. Balloon tamponed. Life-threatening hemoptysis. 4FR 100 cm Fogarty balloon catheter may be inserted by FOB. Inflated for 24 to 48 hours. Role of rigid and flexible bronchoscope in hemoptysis. Advantage of rigid. Larger lumen packing/clearing clots. Improved suctioning. Better clearance. Improved visualization. Continuous opening for airway. Advantage of flexible. Performed at bedside. Access to RUL, distal orifices. Can do lavage. Topical application of hemostatic agents, vasopressor. Cauterization and other procedure can be performed. Special situations. 1. Radiotherapy is often successful in stopping bleeding from bronchial tumors, while other local causes of persistent hemorrhage may sometimes be controlled by bronchial artery embolization. Special situations. 2. Bleeding from aspergilloma may require surgical intervention. Sometimes intracavitary instillation of antifungal drugs can be tried. Footnote. With bleeding from an endobronchial tumor, argon plasma coagulation, APC, or the neodymium, yttrium aluminium garnet, ND, YAG, laser can often achieve at least temporary hemostasis by coagulating the bleeding site. Electrocautery, which uses an electric current for thermal destruction of tissue, can be used similarly for management of bleeding from an endobronchial tumor. Surgical resection. It is a therapeutic option either for the emergent therapy of life-threatening hemoptysis that fails to respond to other measures and elective for definitive management of localized disease subject to recurrent bleeding. Bronchial artery embolization. It involves an arteriographic procedure in which a vessel proximal to the bleeding site is cannulated and a material such as gel foam is injected to occlude the bleeding vessel. Embolization is effective initially in 85% of cases, although recurrence of bleeding may occur in up to 20% of patients over the following year. Pre-embolization bronchial angiogram. Post-embolization. Caution. Medically treated patients probably have a higher risk of rebleeding within the first 6 months. Thank you. Approach to a case of hemoptysis. Learning pulmonology.